Hi, this is Indu Subaiya, and I'm so delighted to be here today to help set the stage for the next few conversations that we're going to be having. I'll be speaking to some observations about trends in health technology, especially as we emerge from the pandemic. I'll be talking about 5 features of the health tech landscape today, and then we'll go into a little bit about the impact of the pandemic, where we saw challenges and opportunities and how we rose to the occasion. The 5 features of health tech today are really marked by this explosion in funding for the digital health sector that we've seen, the growth in scale and consolidation, both in terms of provider organizations as well as technology companies, AI and automation continuing to gain speed, care model innovation, and of course our ongoing issue of data rights and stewardship. Just this year alone, at the halfway mark, we have exceeded last year's total funding for digital health, $14.7 billion as of the end of the second quarter of 2021, compared to $14.6 billion at the end of last year. And this is something that is going to have to be worked out as companies grow and provide returns, hopefully, to those investors. In terms of the top funded value propositions, research and development captured the largest share, followed by on-demand healthcare, fitness, and wellness. But if you look over at the top funded clinical indications, diabetes is right up there, number 3 after mental health and cardiovascular disease for this year so far. And of course, all of this reimbursement and funding is trying to move care from the hospital to the home and into the community, but we still have a long way to go. As you can see, the biggest section of our pie still in terms of U.S. spend on healthcare is in the hospital setting. The pandemic introduced a number of changes to the way we practice medicine, but one of the favorable developments was reimbursement for telehealth services. So Medicare being able to pay physicians the same rate now for telehealth services as they do for in-person visits in many cases, the ability for physicians to waive or reduce cost sharing for telehealth, and allowing physicians who are licensed in one state to be allowed to see patients in other states. We've seen remarkable consolidation among health systems over the last number of years, but this actually got to be a bigger issue during COVID, as big hospital chains bought up competitors with a lot of the federal aid that they were given. And of course, we know the ongoing challenges with large tech, with big tech, and how Congress and other stakeholders are trying to make sure that these large companies don't have a monopoly. But this has implications for healthcare, because Amazon, as well as other players, are introducing telehealth services, have already launched versions of e-pharmacy with the PillPack acquisition, and Apple now introducing features as of even just a few weeks ago with facial recognition software helping to detect depression and cognitive decline. And now in terms of health data sharing, as of September of this year, the ability for your data from the Apple platform to integrate with over 6 EHR companies. So for the integration into the medical record. So this landscape that many of us have seen grow over the number of years that consisted of thousands and hundreds of thousands of digital health applications are really getting consolidated into fewer and fewer organizations thanks to this M&A activity I've been discussing, as well as the consolidation on the provider side. So if you look at Teladoc and Livongo as sort of emblematic examples of this kind of merger, 2 companies that came together in October of 2020 in a very large merger, followed by telehealth startups coming together like Accolade and PlushCare. And this year in 2021, Iora Health, which is a Medicare-focused provider, teaming up with One Medical, a large network of primary care services focused on not the Medicare population, on a more general population, but again, you're seeing this combination around payment models as well as patient demographics. In terms of AI and automation, we've continued apace. Of course, this industry is projected to grow, be about $28 billion in 2025, and it's impacting a number of occupations and services that currently are provided by healthcare workers, from medical equipment preparers to medical assistants and more. And this is going to change the landscape of how we care for patients with diabetes. Whether it's going to be AI in the form of a chatbot, this is an example from oncology. This is a supplement to nurses, not necessarily to replace a nurse, but to figure out, based on patients' symptoms, how to navigate them to the best services that are appropriate for them. And in terms of other diagnostic conditions, the phone being able to now be used for image recognition as well as communication, AI algorithms are working on those elements and allowing consumers to have ready access to either diagnostic questions or guidance on where to seek additional treatment. So care model innovation is something that we've really been watching for a few years, and if I were to take you through one of the biggest changes, I would call it flipping the stack. And if you will, care delivery organizations of the past started out as brick and mortar facilities, adding services provided by nurses and doctors, and technology was brought in almost as an afterthought. It was an infrastructure layer, in a sense, to allow providers to do what they were already doing in a more effective and efficient way. But fast forward to today, and technology in all of its component parts, from enabling data storage in the cloud to transactions to data exchange, analytics, and this interface layer, whether that's voice or augmented reality or virtual reality, this technology stack is now powering a new type of organization where the tech platform is foundational to the structure, and then services are added, provided either by computing or by people, and care delivery is performed by humans as and when it's needed. So an example of this, for example, is Heal Medical, where they provide a house call service with actual doctors deployed to people's homes on demand. But they're using in-home sensors, in this case Wellbe by Qualcomm, to monitor vital signs and other issues, so that a person is only deployed if it's absolutely necessary, and they can triage in that way. The Heal has now grown across the country and is covered by many payers. Medically Home is a hospital in-home platform where conditions as severe as heart failure can be treated in the home, provided there are appropriate remote monitoring capabilities, as well as access to a call center and a nurse practitioner, but again, reducing costs dramatically and extremely platform driven. Virta, which many of us might be familiar with in this community for diabetes, began as a technology company, and they then hired endocrinologists and other providers to treat diabetes, but in a new way, with new clinical protocols where data was streaming 24/7 from patients' devices, and clinicians were activated to provide input with a lot of decision support, and again, only when it was most effective. And this kind of company, again, we call a flipped stack company. It's composed often of an intelligent database. It has an element of continuous monitoring, virtual coaching, and in-person visits as needed, with a feedback loop back into the database. This has now progressed into a new way of describing this company, virtual first care. And virtual first care has to do with this idea that we should be able to initiate care from anywhere at any time, and that in terms of care provision, we really have to match these services to a person's clinical needs and preferences. And it's going to require a whole new set of technology and support for these types of operations, from the back office to clinical operations to the front end, where we're communicating with consumers and patients, as well as acquiring and marketing to folks. And taken a step further, my business partner Matthew Holt has spoken about a concept called the continuous clinic, where we are going to need a new type of organization under which all of these component parts fall, from the individual applications to the staffing to the automated care processes and the underlying big data and algorithms, all tied up into payment and reimbursement. And so this new organization, based on the principles discussed above, may be thought of as the continuous clinic. The fifth element of the health tech landscape, as I see it today, has to do with data rights and stewardship. And this is a subject that's close to many of you who've been doing work in the D-Data movement for many years, but we're really at the point right now where individuals, consumers, and patients can say, it's my data. I really don't just want access to it. I own it, and therefore I can decide if I should even get paid for it, as some entities are enabling, or I should be able to contribute it to science or to specific research organizations where I benefit, as well as helping to benefit the wider community. So organizations like Nebula Genomics and Emblema and Cover Us and Humanity are allowing these at a very granular level, whether it's the use of blockchain or other mechanisms, are allowing patients to share their data in a way that's very specific with value add back to them. And this has even progressed into the world of Web 3.0 for those of you who follow non-fungible tokens. The latest from Nebula Genomics is that your genomic data is, in a sense, a digital identity for you and can have monetary value in the way that these new types of digital elements are being circulated in other industries. With data exchange at the patient level, models like patient-centric solutions, patient share, is a new mechanism using the FHIR API off of the EMR to allow patient-mediated exchange that really reduces issues around privacy and security. And these new models, I think, are going to be the future of how we get around a provider-mediated model and really enable our advocates and our patients themselves to exchange this data directly. In another example from genomics, this is Alice Rathjen's DNA Guide, where you can imagine your genome being a map, literally like a GPS map. They actually use the same software that's used by GPS in your phone to map your genome, but more than that, you'd be given a URL that in a sense would be your entire digital identity from a genomic standpoint, and then you could allow micro consent and bidirectional communication with researchers off of that URL. So again, another mechanism for data ownership and sharing that really privileges the patient and the individual to put them at the center of making these decisions. Well, of course, the pandemic forced a reckoning as we looked out at the health tech landscape, but a number of impacts, I think, advanced us as opposed to set us back. And they had to do with improved access to care, as we had to think about telehealth, financial transparency, as people were hit with huge medical bills and companies then popping up to help us compare prices and to have a lot more information in the hands of the individual. The use of social media, while it was potentially perpetuating misinformation and making life difficult for us during COVID, a number of organizations set out to use social media, whether it was analyzing Twitter to look at mental health patterns or using Facebook data to predict where the next outbreak of COVID was going to take place based on symptoms that people were reporting. But I want to focus on this sort of last element here around what we learned about how we engage people and how we're thinking about health equity. This is a graphic provided by Heiko Health, and I would say that this is something that really depicts so much of what we've learned in the last year, that healthy behavior is not something that is a standalone outcome. It is driven by social determinants, culturally sensitive care and communications, actionable data, not just data, and smart technology. And you need all of this if we're going to really push the needle on healthier behaviors. And we also need to speak the language of the people that we're connecting with. Here is Dr. Lisa Fitzpatrick, CEO of Grapevine Health, where she's leveraging storytelling and community-based support to enhance health literacy and build trust. So this is her doing work out on the streets around diabetes, around vaccine hesitancy, and so much more. In terms of health equity, we really faced a moment where we had to examine the ways in which we were practicing medicine and practicing public health, and really needing to step up to address these gaps in health equity. As we know, COVID did, in a sense, did not discriminate, but did hit certain communities much harder than others, and these data gaps were visible everywhere. But health systems, like in this case, the Delaware-based Children's Hospital, Nemours, health systems stood up. Most that I know of now have a division or an effort or an initiative around health equity, in this case, DRIVE, to look at anti-racism, inclusion, value, equity, and diversity within the context of a children's hospital network, from employees all the way to the patients and the families that they serve. And physicians like Dr. Monica Lipson are ensuring that these ways of taking care of folks that are anti-racist are built into everything we do, from teaching people medicine to practicing medicine and more. So this is really getting embedded in the professions as well as in our culture, hopefully. In terms of health equity, it's really interesting. When surveyed, this is by the Root Cause Coalition, when surveyed, primary care practitioners, nurse practitioners, and PAs said, yes, by and large, I try to address, health equity, if not with everybody, then in unique cases. And they were asked, well, what would make it easier for you to do that? What would motivate you to do that more? And they were asked, well, would being paid for it make a difference? And surprisingly, it was a moderate motivation. But would it help if there were clear pathways embedded in the electronic health record to ensure patients were receiving appropriate help? That was what motivated folks the most. And I think that's really interesting, because that is certainly within our grasp as we think about this increasingly digitized future. So I hope I've sort of demonstrated that we need a new way to think about our challenges and opportunities ahead as we emerge from the pandemic. And we can no longer really separate individualized medicine from public health, in a sense have this schism, but we need a bidirectional integrated approach that thinks about community and public health as we think about individual intervention from a purely medical model. So thank you so much, and I look forward to hearing the discussions the rest of the day. So wonderful. I would now like to bring up my two esteemed panelists to join me in conversation. Shacey Petrovic is a diabetes industry veteran who's been with Insulet Corp since 2013 and took over as CEO on January 1st, 2019. And Mark Clements, an accomplished endocrinologist and researcher who previously served as pediatric vice chair of the T1D clinic network, consisting of 80+ diabetes centers. He has served as Chief Medical Officer of Glooko since 2019. Welcome to you both.
Thank you.
Great to be here.
So I would to start with you, Shacey, in this conversation as we kick off this wonderful conference. Like so many companies in the diabetes space, Insulet has had to transform itself from a strictly medical hardware company into a provider of a comprehensive digital health solution. What are the challenges and opportunities here?
Thanks, Indu. It's great to be here with you. And I think the challenges and opportunities are many. At Insulet, everything we do is focused on our mission to simplify life and improve outcomes for people with diabetes. And when we think about digital and digital transformation, we think about that really as another tool or a new way to deliver on this mission for every stakeholder across the diabetes ecosystem. So when we think first about consumers or people with diabetes, we are simplifying the consumer experience and reducing burden as a result of digital transformation. And some examples of that, Omnipod and AID algorithms are transforming care and bringing more and more people who otherwise might not have been onto new technology. Our next generation system, Omnipod 5, which is currently under review at the FDA, is a great example of how digital transformation can kind of do this on a new level. Obviously, Omnipod 5 is an automated insulin delivery system with an on-body algorithm that doses insulin. It also enables smartphone control and SIM cards. So a lot of digital technology packed into that footprint that will enable better outcomes and improve the customer experience. It also generates a tremendous amount of data. So all of that data and insights that can be pulled from integration with CGM, we will then provide back to users to empower users to hopefully make better decisions with a lot less work. And then I think, the other thing is through the consumer's eyes, our Omnipod and Omnipod 5 are just uniquely suited for some of the new care models that you just referenced in your keynote. And so we're seeing a lot more access to care through telehealth and through virtual training. So that's sort of the consumer side of things. Then if we think about the healthcare practitioner and the clinic, we are using digital to help streamline care delivery. And, today clinicians can get really easy access to Omnipod Dash data through the cloud and our partnership with Glooko. And with Omnipod 5, because we've added SIM cards into the handheld controller and phone control, it means even more real-time and more immediate access to data for the clinician. And then finally, if we think about the payer, our goal is to improve outcomes and reduce cost. And an example of that, we published and presented really exciting outcomes with Omnipod 5. And because of the data and digital capabilities that are wrapped around Omnipod 5, it helps us to demonstrate this data to payers in a really compelling way. We can actually share population-based data analytics that demonstrate to payers outcomes data for their particular group of beneficiaries, just as an example. So we really do look at the opportunity to transform care through digital tools and transformation across each of the stakeholders. I think, the challenges are plenty because we are hoeing new ground here, and digital is transforming every industry, but we are pioneers in bringing new digital tools to people with diabetes. You can see that in new regulatory pathways like breakthrough devices and interoperability, and we applaud the FDA in creating these new pathways, but they are new, and so they require new standards, new documentation, new technologies, new teams, and just an enormous amount of investment and innovation. And so that's a challenge in itself. We've been working with the FDA to make smartphone control a reality. And that's just required an enormous amount of investment and new capabilities and new partnerships. And then when we think about our side, it's, just new capabilities and teams around cloud, algorithm, integrations, phone compatibility, and just even new mindsets for our teams like Agile. So no small undertaking, no shortage of challenges, but I think the enormous opportunities to improve the lives of people with diabetes just warrant tackling these challenges.
That's a really comprehensive vision of I would say, the transformative power of digital in all of these sectors and for all these stakeholders. And Mark, an opening question for you. As we look at Glooko, you went from a focus on personal blood sugar data to big data analytics and prediction at the population level. Tell us a little bit about this change and what Glooko hopes to achieve.
Sure. So when Glooko started in 2010, it was, as you said, a company that was dedicated to unlocking the power of data from medical devices and making those data available both to the person with diabetes to use in their self-management in easier and simpler ways, through their mobile device, and also to share with their healthcare provider. But over time, you've really seen a transformation and evolution of what Glooko has become. So we are one of the largest platforms for integrating diabetes device data. We integrate data from 95% of devices on the market, including our very important partnership with Omnipod and Insulet. And we are starting to understand how to take data not just at an individual level and present them to a person with diabetes to help improve their self-care and to present them to their healthcare provider to improve their care during clinical interactions, but also to present those data in population health reports in ways that will allow providers to begin to differentiate care. One of the big problems I see in diabetes care today is the fact that we follow consensus guidelines that really lead us to providing one-size-fits-all care. And it is really time, and we're really starting to see with the innovation that's happening both in the academic sector and in the industry sector, time for us to begin to understand how to personalize diabetes care. I've watched with envy as oncology and pharmacogenomics have capitalized on the term personalized medicine and precision medicine. And, you know, diabetes, if you think about it, was really the original disease state that was, I think, the birth of personalized medicine. Because in no other disease state do we have to make so many decisions on a daily basis, up to 180 additional decisions to try to optimize self-care, right? So if we can start to help clinicians to identify those individuals who need the most help at the present moment and who perhaps need a particular type of help, then those clinicians can start to deliver care in a continuous clinical model using remote patient monitoring and the approach of integrating various digital interventions or digital behavioral interventions into their care. So we are starting to enable population health because we think that clinics are asking for it. We think that clinics are trying to quality improve care across entire populations. We know that if you look across countries that have implemented learning health networks, as in Europe and the US, that you're beginning to see significant improvement in glycemic control across those populations that have implemented some form of learning health network with population health approach. I think that also as we expand out into the population health realm, we're also zeroing in on this new era of personalized medicine, which I think relies on precision engagement. So we're starting to understand how to use the data to help identify just the right moment and just the right behavioral nudge or intervention in order to help the individual with diabetes meet their personal health goals. So really we've seen a transformation from a device data integration company to a company that is providing remote patient monitoring and continuous care between clinic visits and helping really to strengthen the therapeutic alliance between patient and their trusted healthcare provider.
That's fantastic. And you are also echoing this idea of data at the population level and data at the individual level, and how really it's not about trade-offs, it's about all of the above. So I'd love, Shacey, for you to build on that, because you also spoke about the different stakeholders for whom you're providing data, including payers with outcomes data at these segmented population levels, but with smartphone control and body, designed algorithms, we're talking about highly individualized treatment and interventions. So I would love you to speak a little bit more about your vision for the personalized aspect of this future Mark is talking about, but talk a little bit about the role of the innovator advocate, because this is a community of folks who have been at this for so long, but they have a voice in how we really realize this vision of the personalized future of diabetes care. So I would love to hear your thoughts on what you're doing to even further personalize care, and then what are some of the ways in which innovators and data evangelists in the community can really step up to expand on that?
Yeah, it's a great question. I think, when we think about personalization, we see just tremendous opportunity. I guess I take a step back and say, there are sort of three trends that we're really focused on. One is the explosion of data, as a result of integration with CGM, as a result of going to the phone and having access to information on the phone. There's just tremendous advancements happening in the collection of data and then the application of data to improve outcomes with diabetes. And, we're right at the forefront there with Omnipod 5. We believe we can take a lot of that data and generate incredibly valuable insights for the user, and Mark spoke about that, but also for the clinician and the payer at a population-based vantage point to be able to improve care, streamline care, and improve outcomes. The other trend that was mentioned in your keynote, Indu, is just this trend of consumerism. We see this growing volume or growing base of informed and engaged patients. And to your point, our goal is to leverage that engagement to improve our innovation and improve how we serve insights up to our patients. But we think that this consumerism is going to also drive new payment models and increase transparency. And so, we believe those are good trends for us. And then finally, COVID, and you highlighted this, has just really accelerated capabilities and driven adoption of new tools and care models for all of the stakeholders. So I think when we think about opportunities then on the personalization side, we believe that this data can be leveraged to develop better, more personalized solutions targeted to the data, and to be able to translate the data and insights into action, to be able to take the burden out of diabetes and help people make decisions with a lot less work. I think, we also look at access to care and new care models as great equalizers. And, this is particularly important in areas where, in the country where there aren't endos or access to care, or as frequent access to care. And we've actually seen great success with that with Omnipod, particularly in the type 2 segment, in part for, those reasons and those trends. As it relates to, innovators and individuals and advocates who can help us, I think, I'd be remiss in not sort of saying thank you off the bat, because we would not be right here, right now, on the cusp of delivering phone control and this new technology without the diabetes community. You could argue that a lot of the pathways that the FDA have created is as a result of the voice of the diabetes community and some of the innovation that was happening, in the community, that really helped to accelerate industry innovation and pathways to bringing this innovation in a studied way to the market. So that's very exciting. I think, we at Insulet pride ourselves on engaging our patient population in the development of our technologies. And when I think about even just Omnipod 5, we had about 5,000 participants in the development of the user interface in our user research. We had, many more people involved in market research studies, human factor studies, other type of innovation studies. So the technology really is born of, the community of people living with diabetes and their caretakers. And I think that's what ultimately allows us to bring the right technologies to market. And when we think about our future pipeline, I think that's where the community of advocates, in two fronts, right? One is developing the right technologies, and the other is ensuring access for them. And the community has proven to be incredibly powerful on both of those fronts. And that's why I highlighted the trend of a more engaged patient population. We now have platforms like social media that allow groups of patients a loud voice as it relates to the payer, as it relates to regulatory bodies, and as it relates to industry. And shame on us if we're not listening to them, engaging their voices, engaging that powerful position to be able to develop the right technologies and then get them accessed to the community of people living with diabetes.
I really loved the point about the voice of the individual, the consumer, the patient community, driving not just the product roadmap, but the access issues and how we have to innovate around that as well. So we'll come back to that in a minute. But I want to go to Mark, and Shacey mentioned just now in her comments that Omnipod 5 and this suite of products is really helping to address issues where there may not be enough specialty care in parts of the country. And you are yourselves are working at this intersection of the provider-patient relationship. So I'd love you to speak a little bit to, again, how Glooko is supporting the day-to-day clinical encounter, and what are some of the challenges and barriers to unlocking the potential there of both provider shortages, again, and patient engagement?
Sure. Well, a core competency for Glooko is obviously the display and visualization of information in a way that yields insights, that reduces cognitive burden, both for the person with diabetes and for the healthcare provider. As you know, we have a platform that allows individuals with diabetes to share data on the go, sometimes via their mobile phone, sometimes via computer. They can share data with a platform that their healthcare providers can use to visualize the entire patient population of that clinic. And the way that our reports, if you will, and our web portal are designed, it really follows the decision-making heuristics that clinicians use. So as a clinician, as an endocrinologist, there are certain things that I want to see. I want to see the distribution of blood glucose values across the range. I want to see how much time in range there is. I want to see how much time the person spends high and low and very low. I also want to see the distribution of insulin. So we really try to provide those high-level views up front, and we use the voice of the clinician to tell us how they're making decisions so that we can prioritize what the display looks like. We're also able then to drill down deeper and deeper to follow really the clinician's decision-making heuristics, so that if a clinician wants to uncover whether there are certain behaviors in self-management that are relating, for instance, to a high glucose or a low glucose after a meal or after exercise, they can do that, and they can use that as really the stepping stone for having a conversation with the individual about their daily diabetes self-management. So, drilling down and down and down until you get to really the core issues that might be impacting glycemic control on a daily basis. Now, I know as well as anybody in the audience today that an endocrinologist is going to really sort of geek out about the data. A person with diabetes who's really got a stake in their own data is going to be very interested in the data. But primary care providers out there are seeing diabetes patients as approximately 5% or so of their total patient populations. And they may have 12 minutes or less for a clinical encounter. So those individuals are going to struggle to drill down and down with the data like we endocrinologists do. But I don't think it's necessary always for us to drill down as deeply or as thoroughly as we do as endocrinologists in order for a primary care provider to have a deep and positive impact on a person's self-management. And so to that end, we are really taking several actions to try to support primary care providers who are already caring for the majority of diabetes patients in the United States, who are already caring for the majority of individuals with diabetes globally. The first is really to understand how they think about diabetes data. And the truth is that they want to think about it just enough to provide the support and get the job done. And what tools can we provide to aid them in that? So, for instance, Glooko has a mobile insulin dose titration system that helps individuals who are starting a new type 2 patient on insulin the ability to set a titration algorithm and allow that algorithm to continue with some automation after they leave the office, so they don't have to come back every time they're going to adjust that new insulin. We also have partnerships with other digital therapeutics companies that allow the titration of insulin for basal and bolus dosing, for instance, from an insulin pump. Finally, we are thinking a lot about how to provide education to non-specialists. So we have a program in the UK that we're very proud of called the ABCD Academy that is providing education to clinicians on diabetes technology to help them develop the core competencies they need, so that when they see this, the multitude of devices that come through their clinics, whether those are blood glucose meters or CGM devices that they might be seeing for the very first time, gives them the ability and the confidence to, with very sort of short and focused video education, provide the care and advice that that individual needs today. I would say, finally, we're again thinking about the continuous care model and how can technology serve as an extender for general practitioners as well as endocrinologists. So we know that diabetes is a majority self-management disease, right? So we have tools. The tools help us to achieve certain outcomes, but one has to engage with the tools of the trade, if you will, in the optimal way to achieve those outcomes. And while our colleagues at Insulet, for instance, have done a really fantastic job of trying to ease the cognitive burden of individuals with diabetes by creating these fantastic algorithms, there are a lot of individuals who are not currently or will not in the near future be using a hybrid closed loop system of insulin delivery. So how do we reach the world of individuals who are self-managing in an open loop world? Well, one of the ways to do that is to really think about context around glucose values and to think about how to surface to them insights and behavioral nudges. So you're going to see in the near future, Glooko really putting a lot of attention to how do we create contextual data around the glucose and insulin data that will help an individual to self-manage related to exercise, related to the foods they eat, etc.
And I'd love to build on that because I think that's incredibly important, this dual component of education, both for the non-specialist as well as individuals who might not be as engaged as some members of our community living with the condition. And also how we kind of build those supports for context and interpretation. So Shacey, on that front, what steps is Insulet taking to broaden access to a diverse population of individuals living with diabetes in terms of medically underserved populations, but also perhaps clinicians practicing in these communities where, like, Mark said, they may just not have seen one of these devices, might be the first time, or in their clinical environment, the digital transformation that you've spoken of might be a few steps behind.
Yeah, I think a few things. The first thing I would start with is just the simplicity of the technology. And so, the simpler the technology, the more easily it can be used by a broad range of people of different socioeconomic backgrounds, different types and diagnoses of diabetes, different age groups, et cetera. So, our mantra as it relates to the choices we make around innovation is entirely about simplicity. And so I think that's, foundational. The next thing I would move to is awareness. We have started to invest in awareness and direct-to-consumer advertising with a view towards making more and more people aware of the technologies that are available to them. That's true for type 1 and type 2, and that awareness is also generating awareness among clinicians, both endos and PCPs. So that certainly is working. And then the third thing I would point to is just traditionally what we think about as access. Back in 2019, early 2019, we moved our technologies into the pharmacy channel. Most traditionally, durable medical equipment, insulin pumps, traditional insulin pumps are available through the DME channel. The DME channel, it can be challenging because it has large upfront deductibles and lock-in periods, 4-year lock-in periods for technology. And as we think about digital transformation and more rapid innovation, we want to ensure low out-of-pocket costs for patients, and we want to be able to ensure more rapid access to innovation as iterations happen through digital transformation. And so the pharmacy enables that. It enables access for people with both type 1 and type 2 diabetes, whereas in the DME channel, it can be restricted for type 2. The pharmacy ensures low, predictable out-of-pocket costs. So the vast majority of all of our pharmacy patients are getting access for less than $50 a month copay, some of them a lot less, many of them zero. And then we also don't lock people into 4-year contracts. So this idea that you have to wait 4 years or pay an upgrade fee if you're going to try to get access to new technology before that 4-year warranty is up, we've eliminated all of that. There is no upfront cost. And when new technology is available and the insurer covers it, then it's available for the user without an upgrade fee or having to wait out a contract. So all of these, efforts are as a desire to be able to bring our technology to more people. And the last thing I would say is that We sort of reiterated this commitment with Omnipod 5. Omnipod 5 is remarkable technology that is demonstrated in our pivotal study improved outcomes. And there's a tremendous amount of technology built into this next generation system. And yet we have committed to offer it at price parity to our current system. And that's to ensure broad, affordable access for all sorts of users, both type 1 and eventually type 2 when we have that label expansion. So, it just demonstrates our commitment to ensuring that as we bring new technologies to market, that they're available to all people, regardless of diabetes diagnosis, regardless of socioeconomic background, and all of the challenges that come with certain demographics getting access to technology.
That makes a ton of sense to kind of use sort of a four-pronged campaign to increase, access. And Mark would love you to comment on this in a second, but this idea of, community-oriented distribution channels like the pharmacy where people live, hopefully just a few blocks from most people's place of residence is a place that they can access it, is wonderful. And coupled with the lower costs and the increased awareness. So that's great. For the work of Glooko, Mark, as you think about building an even more data-rich environment, which has a lot to do, I think, with sort of the missing link of patient behavior or individual behavior, what is still missing from the landscape, from your point of view, that would make the data more predictive? And what are some of those barriers, and kind of what do you hope to see happen to lower those barriers?
Sure. There are a few things I can call out. One is that a fair number of devices on the market still are not Bluetooth connected, and if those devices are Bluetooth connected, the vast majority of them still don't share data passively, right? And we really think that the model for passive data sharing to, again, reduce the cognitive burden on the person with diabetes is the way to go. If you look, their continuous glucose monitoring devices were the first devices to sort of really promote passive data sharing. And now, of course, with Omnipod and with some other insulin pumps trailing behind, we've got the ability to passively share insulin data. Objective insulin data was a big problem at the beginning of the COVID-19 pandemic, because if people were not able to upload their devices from home, then that is missing context or missing vital information for the provider to help guide the individual with diabetes. So I think as we continue to see devices become smarter, more connected with a mobile phone or with a cloud ecosystem, we're going to see less cognitive burden on the person with diabetes and just more help from the healthcare provider. I also think that one of the issues that we have to recognize is that there's a disparity that exists in the promotion and connecting of advanced technologies to persons who are either economically disadvantaged or who are minority. This has been documented in studies in the T1D exchange and beyond. And I think that in order to close that gap, we're going to have to figure out how to reduce the gap in access for these devices, because it's not just that you don't have an advanced technology for your self-care, you also don't have access to these advanced technologies that share data passively and easily. And so as a healthcare provider, one of the disparities that I see is that individuals who are socioeconomically disadvantaged or who may have other social determinants of health-based barriers, to their medical care, are also missing data, meaning that they're not able to get their data across the last mile to me as a healthcare provider to help me help them in decision making. So I want to make sure that as we evolve from a primarily brick and mortar ambulatory care approach to diabetes to a more continuous model that involves remote patient monitoring, that we're not leaving out an important segment of the population in the US and beyond. I also just want to point out that I think that we have a disparity not just among individuals and their access to care, but we also have a disparity among clinics across the United States. The ability for federally qualified health centers, for instance, to access some of the technology that they need in order to integrate data, in order to visualize the outcomes that some of the larger health systems can visualize is a problem. And one of the things that Glooko has done is it has partnered with AmeriCares to provide its platform to these federally qualified health centers, post COVID-19 pandemic, so that they can access the tools that academic centers and other large centers can access.
So to build on that, Shacey, how do we manage this sort of system of checks and balances, if you will, on the one hand, to leverage these fantastic partnerships that both your organizations have built to allow the more passive and seamless exchange of data, against the very real concern that many people in our community here today have been working around, which is around data rights and privacy and security. So how do you kind of balance that at Insulet, and tell us a little bit about some of your recent developments around data privacy and protections while still keeping things moving? I think you're on.
It's an interesting question because, I think while it's true we want passive sharing of data, as we gather more and more enormous volumes of data, it has to provide value ultimately back to the consumer, and it has to be through the vantage point of patient consent, because we believe fundamentally that the data is the patient's. And so, I think it's an interesting question. I also think about the power of integration of these systems, which then unlocks the data. And that's very important. And so, part of what we're challenged with is a lack of standards around integration of technologies, because, ultimately today, even though we talk about interoperability of devices and technologies, still every single one of them is its own beast. There are no standards in terms of information exchange, cybersecurity, standards of communication and connectivity between devices. And so while we want ultimately plug and play, it really doesn't exist that way today. And so each partnership is a significant investment of time. It's a significant exposure of IP and how technologies work. And so we don't really have true interoperability. We have very close partnerships with significant investment that ultimately, require thousands of scientists between, for example, Omnipod, Dexcom, and Abbott. We have tremendous investments beyond the technology. And so these are not, each one is a bespoke integration. It's not true kind of interoperability. I think ultimately, we have built our approach just based on key data principles. We believe users own their data. They need to be able to choose who they share their data with, and that's balanced with the investments that are required to be able to enable that to happen. And so it has to provide value back to the ecosystem. Otherwise, there are more important things we could be investing in to improve outcomes for users. We want to allow for the communication of the right data at the right time to Mark's point, to be able to ultimately drive action and nudge the right behavior to help the user. And I think ultimately a lot of our investments have been around cybersecurity and how do we ensure the integrity of the data, data stewardship, and the security of information exchange between these devices. I think Mark alluded to it earlier when he was comparing us to oncology, but there are very few disease states where we are asking the user to dose themselves with a potentially lethal medication. We have to ensure that the system is completely secure and that we're doing everything that we can to address all safety concerns, et cetera. And so that's where a lot, we've made enormous investments on that front. And enormous investments in terms of integration with different sources of data and devices like our CGM partners. And that unlocks the data, and then ultimately we have to respond to the user's needs so that we generate the right insights to help them get better outcomes.
Indeed. And so, Mark, how would you respond to this sort of challenge of, if you will, open data in a closed loop world, right? How do we, what are the innovations you are either working on or want to see happen in terms of interoperability to ease some of the burden of these one-off bespoke integrations and partnerships that Shacey's talking about? I would imagine you guys at Glooko, given the number of integrations you do and the number of partners you have, are thinking about this a lot.
Yeah. So first, I just have to say I agree with Shacey 100%. I think that we have to acknowledge that the person with diabetes is the owner and first and final authority over their own data. And until manufacturers start to recognize that, we'll never achieve interoperability in a way that provides meaningful value to individuals with the disease. So I would love to jump on that train and champion that with you. I believe in it wholeheartedly. I think that at the same time that we're championing the person with diabetes as the authority over their own data, we also have to recognize the interest and the importance of protection of that data and privacy. So, that's why we have invested significantly in becoming HITRUST certified and ISO certified, so that we are HIPAA compliant and GDPR compliant. And at Glooko, we sort of hold the relationship with the person with diabetes as a sort of sacred relationship. We, if we don't have their trust, then what do we have? So I think that rather than some new innovation or new technology in order to advance interoperability, what we need first is to acknowledge the need to respect the person with diabetes and to place them in the position of authority over their own information.
Great point. And I think the issue of trust, I think, resonates throughout this whole conversation. And as we kind of think about wrapping up this wonderful conversation, I want to ask you both sort of a three-part question. As we emerge from the pandemic, and hopefully it truly is an emergence from the pandemic, we've made progress, surprisingly, as a digital health industry, right? We discussed this in the opening remarks around, advances in reimbursement, advances in the uptake of telehealth, the kind of reality of virtual first models of care. So it was a kind of a massive setback for us from a human capital standpoint, but in a way, through the tragedy and advancement on the digital health side of things. That said, if you were to think of the different stakeholders you touch, I'd love to ask you, Shacey, as we wrap, what is still left on the table? If you could address, and I would say regulators, payers, clinicians, and folks living with diabetes, what is the one thing that we can do to move things forward in each of these categories that we still haven't pushed forward as much? Yeah, and I would ask the same question of you, Mark.
Yeah, it's a great question, Indu. I think first, I think this is a good opportunity to just celebrate how far we've come before we dive into what is still left to do. I mean, it's just incredible where we are. There's no better time to be living with diabetes than today. When we think about where we are today, we've got integration with CGM, we've got integration with our partners' pipelines, and we look forward and see the opportunity to drive just more and more simplicity to help people get better outcomes with less work. And we see generations of our technologies that can help us do that in bigger and bigger ways as we look forward. I think, if we think about what's still left to do, I mean, it's almost enormous, right? We, to Mark's point, we have to drive better access. We have to drive more simplicity of our technology so that truly everybody who lives with diabetes can benefit from the technology and the enormous potential of digital transformation and data. I would say if I were going to point to one thing across the ecosystem, I would point to standards. And I mentioned it earlier, but full interoperability in the way that I think it was initially envisioned by the diabetes community can't really come without standardization around how devices connect to one another, how data is secured and exchanged between ecosystem data partners, et cetera. And I think that standardization would enable a lot more simplicity in terms of how we offer value back to the ecosystem across each one of those stakeholders.
Thanks so much, Shacey. And Mark, if you had a rallying cry or a call to action as you look across the ecosystem, what is the sort of highest yield change we could make moving forward?
Sure. When we look over the next 5 or 10 years, I think we're going to find that unlocking the behaviors of the individual in their daily self-management are going to become key to continuing to advance diabetes outcomes and quality of life. And we have to do that in a way that is not imposing and not burdensome, right? But as Shacey said, actually reduces the cognitive burden on the person living with the disease. It has to be simple and elegant. So I think that one of the innovations that we're really missing is the innovation that helps us place diabetes data, glucose data, insulin data in the context of everyday living. We need to find simple, passive, and better ways to put those in the context of physical activity, put those in the context of eating, even put those in the context of the emotional or psychological state of the individual. And once we do that, I believe we will be able to develop intelligent systems that can really, in a low burden way, help the person achieve their health goals. I also just want to echo the rallying cry here for interoperability, because I think that is the key to all of it. To the degree that we have to spend dollars and time and scientific resources trying to overcome the barriers to interoperability, we're missing the opportunity for lots of innovation. So thank you.
So thank you both today for joining me for this wonderful conversation. I want to congratulate both your companies on being models in a way of reinvention, of collaboration, of partnership. And it's really, really exciting to see both of you leading your organizations toward this new frontier. So thank you so much. And we will now be turning this portion of the conversation into an audience Q&A. Thank you again.
Thanks, Indu.
Thank you.